Good morning, everybody. Thanks for being here. We're going to be talking about support for patients who are using Premarin and hormone replacement therapy. So we're going to be talking about the different functions of estrogen and progesterone and differentiating between bioidentical hormones, conjugated estrogens, which are also known as Premarin, and synthetic hormones. We're going to be assessing the roles of the estrogen quotient, which is the EQ, and the PG-E2 ratio in clinical practice. You will gain natural treatment options that support favorable estrogen metabolism and will help you to address estrogen dominance. We're not getting any younger. A woman's life expectancy has increased from age 47 in 1900 to age 80 in 2005. This translates into nearly 4 decades of life after menopause. For millions of women in the US, it's time to get serious about hormone balancing and health optimization for the long term. Estrogen equals growth. We're going to talk about that a little bit more in greater detail. There are many functions of estrogen in the body. We think of estrogen as being something that promotes growth. It is responsible for the development of sex characteristics in menarche. It stimulates the growth of endometrial and breast tissue. It stimulates the development of the follicle. It stores fat. It protects against bone loss, something that's very important for women who are postmenopausal. It supports vaginal tissue. It maintains collagen in the skin and in the connective tissue. It aids in the synthesis of neurotransmitters, especially serotonin and dopamine, and it aids in the glucose transport across the blood-brain barrier. There are 3 naturally occurring estrogens: estrone, estradiol, and estriol. And you can remember them because of the little clues that are that are hidden in the names. So estrone has the number 1 in it, and we call that E1. Estradiol has diol, which means 2. Estradiol is E2, and estriol has the triol in it, which is means 3. So we call that one E3. Estrone, or E1, is the most prevalent estrogen in postmenopausal women. It's 50 to 70% less biologically active than E2. We're going to be talking about E2 next. It's made in the ovaries and peripheral tissue in premenopausal women. It's mainly produced in fat cells via aromatization in postmenopausal women. It converts to both estradiol and estriol. High levels of E1 are associated with an increased risk for estrogen receptor positive breast cancer. So when we think of E1 or estrone, this is the estrogen that has the most potential for harm. Premarin is approximately 50% estrone. Estradiol, or E2, is the most potent and active estrogen. It's made in the ovaries as well as in the peripheral tissues. It acts as a growth hormone, stimulating growth and the proliferation of tissue. Aromatase converts testosterone and DHEA into estradiol, in particular, especially in the adipose tissue. And because they are biochemically interconvertible, E2 yields the same family of metabolites as E1. And we're going to be looking at some charts that will make that a little bit more clear to you in a little bit. Estriol is the weakest of the 3 estrogens, and it's the estrogen that we think of as being the most protective. It binds to the same receptors as E1 and E2, and as a result, it serves as a competitive inhibitor. Estrogen receptors have a greater affinity for estriol than they do for E1 and E2. The only time that endogenous estriol is high is during pregnancy. And it's produced when it's converted in the liver from estrone and or estradiol. And it's important to know that E3 does not convert back into estrone or estradiol, and we'll see that coming up. So here is just a graphic representation of what the three molecules of estrogen look like, the three different estrogens, and you can see how similar they are. So what is Premarin? Premarin is the brand name for a type of hormone replacement therapy that comes from the urine of pregnant mares. It consists of a combination of many estrogens called conjugated estrogens. It's available in oral form and as a cream, and it's been manufactured by Wyeth since the 1940s. Is Premarin bioidentical? No, Premarin is not bioidentical. Bioidentical hormones are identical in their molecular structure to those that women make in their bodies. Bioidentical estrogens are estrone, estradiol, and estriol. Premarin contains many different estrogen sulfates, which are also called conjugated estrogens, which are metabolites of equine estrogen, and none of them are bioidentical to human hormones. So I'm not quite sure what happened to this slide, but it was showing you that estradiol and Premarin are not the same. They're very similar in structure, but they are not the same. There are many different estrogens in Premarin. And you can see in the slide that I highlighted the few that are the most similar to human estrogens. You'll see that I've highlighted sodium estrone sulfate, which is 49.3% of the estrogens in Premarin. You can see that I also highlighted estradiol sulfate, 4.5%, dehydroestrone sulfate, 3.5%, and then you'll see another estradiol sulfate, two other estradiol sulfates, but you'll see the rest are not similar to human estrogens. Just to give you an idea that there are many, many different estrogens in Premarin, all of them being downstream metabolites that are found in the urine. Similar, but not the same. Bioidentical estradiol, on the other hand, there are several different pharmaceuticals that do make bioidentical estradiol. Some of those brand names that you might recognize are Estrace, Estrogel, Evamist, Vivel, which are the patches, Climera, Alora, Estroderm, Vagifem, Estring, and others. These all contain bioidentical estradiol, which are bioidentical to human-produced estradiol. It can be compounded into a cream or a troche form from compounding pharmacies, and it also exists in the form of pellets and patches. Keep in mind that compounded formulations are individualized based on a patient's test results and individual needs, also their symptoms and clinical history, and one can combine several different hormones into one formulation. So oral versus topical. It's important to understand the differences between the two. Oral estrogen, whether it's a synthetic estrogen or even a bioidentical estrogen, is going to impair the metabolic action of growth hormone in the liver. And it's because of the first pass effect. Whenever an oral hormone is taken, it's going to go through the liver and it's going to be susceptible to the first pass effect. This results in a decrease in insulin-like growth factor. It increases fat oxidation, and it also causes a loss of lean tissue and a gain of body fat in postmenopausal women. Oral estrogen also increases inflammatory markers and acute phase proteins, including serum amyloid A and C-reactive protein. These effects are not found with transdermal estradiol because it bypasses the liver. And there's quite a bit of information there that goes into greater detail that you can see in the references if you'd like to do a little bit more reading on that. Progesterone, on the other hand, so if we think of estradiol as growth and proliferation, progesterone equals differentiation. First off, let's talk about the difference between progestins and progesterone. Progestins are a synthetic form of progesterone. They are not bioidentical. They are also known as progestogens. They have a different molecular structure, which you will see in the next slide. They do not have the same effects as bioidentical progesterone, and they actually have many negative side effects. So here you can see on the left, on the top is the bioidentical progesterone made by the human body, and below it, medroxyprogesterone, or a progestin, a synthetic progesterone. Synthetic progestin, you can see again that the molecules are similar, but they are not the same. And on the right, just as a comparison to show you, you can see estradiol and testosterone, again, how similar those molecules are, but they certainly are not the same. So it's just important to note that because molecules look similar does not mean they're going to have the same action in the human body. So we like to say that comparing progesterone to progestins is like comparing apples to oranges. A French study compared women using estrogen in combination with a progestin versus women using estrogen in combination with bioidentical progesterone. And they found a significant increase in the incidence of breast cancer with the progestin group and no increase in the group using bioidentical progesterone. And this is because of the functions of progesterone. Again, its role is to oppose the effects of estrogen in the breast, the brain, and endometrial tissue to counterbalance those proliferative or growth effects. It stabilizes and induces secretory endometrial changes. It promotes sleep patterns. It has a calming effect on the brain, and it helps to increase GABA receptors. It's essential for maintaining pregnancy. It improves estrogen receptor sensitivity. It promotes glucose utilization, and it improves insulin resistance. It enhances thyroid hormone activity by decreasing thyroid binding globulin, and it increases scalp hair. As well, it helps to burn fat for energy. It's a diuretic. It has antidepressant qualities. It can reduce cholesterol, inhibit coronary vasospasm, promotes osteoblasts, so it's beneficial for bone health. It promotes cell differentiation, again, the opposite of estradiol, which is about proliferation, and it promotes cell death, specifically when we're thinking about cancer. So here is the father of what we call estrogen dominance. The person who coined the term estrogen dominance, this is Dr. John Lee, MD, and he worked with a lot of women in his practice around the use of hormones. He wrote the book called What Your Doctor May Not Tell You About Menopause. He found that progesterone treated many of the issues of estrogen dominance. And he found that progesterone supplementation could address osteoporosis and estrogen-dependent cancers. He found that progesterone supplementation alone can be especially good for women who aren't candidates for estradiol supplementation due to a family history or a personal history of estrogen-driven cancers. So he worked with a lot of women and felt that the ongoing issue for so many women was that there wasn't enough progesterone in their body to counterbalance the effects of estrogen. And he found that these effects were worsened by what are called the xenoestrogens, which are the synthetic estrogens in our environment. He also found that estrogen dominance was worsened by just poor estrogen metabolism as a result of gut health not being maximized and poor diets contributing to that. He also found that insulin resistance played a role in worsening estrogen dominance and anovulation. So here's what your report is going to look like from Labrix. This is where you can see the PGE2 ratio. You'll see in this example, this woman does not have an excessive amount of estrogen. You can see the range is 0.5 to 3.2. This woman's estradiol level is at the very bottom of the range at 0.52. As well, her progesterone is also very low. In this case, we're using the supplementation range of 500 to 3,000 to show you that her her measure of progesterone at 68.8 is quite low. And the ratio is 132.46. We'd like to see that somewhere between 200 and 600, because that's what John Lee found as being the range where women's symptoms improved and their health received the most benefit. So again, we're shooting for the PGE2 ratio to be in that 200 to 600 range. So some signs and symptoms of progesterone insufficiency or estrogen dominance: irregular menstrual cycles, irritability, mood swings, all the things that we would associate with PMS, even accelerated aging that you'll see oftentimes in women as they become more perimenopausal. Even things like anxiety can be attributed to estrogen dominance, bloating, ovarian cysts, an increased risk of postpartum depression, increased risk of blood clots, increased risk of breast cancer, increased risk of gallstones. Some more symptoms: cognitive concerns, weight gain, breast tenderness. Again, some more, also fibrocystic breasts, decreased libido and uterine fibroids, all kinds of things that we would associate with PMS or that cyclical process, monthly cycle for a woman. Food cravings, headaches, heavy menstrual periods, hypersensitivity, and increased triglycerides. Again, this doesn't just happening to women who are cycling. We're also going to see estrogen dominance in peri and postmenopausal women. The Women's Health Initiative was a long-term national health study to help determine the causes of heart disease and cancer in postmenopausal women. In June of 2002, the conjugated equine estrogen and medroxyprogesterone, so that means Premarin and progestin, and that pharmaceutical product is called Prempro. That arm of the Women's Health Initiative was discontinued after 5 years instead of the planned 8.5 years due to several increased risks that were found in the process. There was an increase of invasive breast cancer, a 26% increase of women who were using Prempro than for women who weren't. There was also an increase in heart attack risk, 29%, 41% increase in stroke risk, Alzheimer's and dementia, and also pulmonary embolism, huge increase for women who were in the Prempro arm. Interestingly enough, there was also evidence of a decreased risk of colorectal cancer and hip fractures for the women who were using Prempro. Some other additional risk for women who are using HRT, and again, the HRT stands for hormone replacement therapy, which does not equal bioidentical hormone replacement therapy. So anytime a woman is using synthetic HRT, they have an increased risk of breast cancer. Especially worse if they're overweight, if they have insulin resistance, or if there's any iodine insufficiency. They have an increased risk of gallbladder disease if they're on synthetic HRT. Again, an increased risk if they are overweight, and an increased risk with estrogen dominance. They also have an increased risk of endometrial hyperplasia and cancer. Again, worse overweight and worse with estrogen dominance. And just in general, the greater a woman's exposure to estrogen over time, the greater her risk for hormone-related cancers, including breast, endometrial, and ovarian cancer are. So just keep this in mind with your patients who have been on unopposed estrogen for years and years and years, even if it's bioidentical. So when we're looking at estrogen, we're thinking about how best we're going to support the favorable pathways, and that's really important. There are 3 different metabolic pathways, or ways in which the estrogens can be broken down in the human body. There is the 2-OH, the 4-OH, and the 16-OH pathways. The 2-OH metabolite pathway has a weak estrogenic activity, and it's associated with a lower cancer risk. So the 2-OH pathway is the favorable pathway. The 16-alpha-OH and the 4-OH metabolites show persistent estrogenic activity, and they promote tissue proliferation. The 16-OH is associated with many cancers, including breast, prostate, pancreatic, gastric, osteosarcoma, and ovarian. The 4-OH estrone is readily converted to 3,4-hydroxyquinone, which is a potent carcinogen in the presence of free radicals. So we're going to talk about this pathway just a little bit more. So you can see here the three molecules of estrogen: estrone, estradiol, and estriol. Of note that you will see that both estrone can convert into estradiol, and estradiol can convert into estrone, and both of them can convert into the more protective form of estrogen, which is estriol. You will note that estriol, there are no backwards arrows, so if somebody is using a supplemental estriol, it is not going to convert into estrone or estradiol. That's an important thing to understand when you're putting somebody on bioidentical hormone replacement therapy. And you will note the harmful 4-OH and 16-OH metabolites coming from the estrone pathway. And you'll note also, as I just mentioned, that estriol is the end of the line, or can be the end of the line. The estrogen quotient is another tool that we use to evaluate a woman's hormonal status. It was developed in the 60s and 70s by Dr. Henry Lemon, who noticed that women who developed breast cancer had very low levels of estriol, or E3, the protective hormone, the protective estrogen. He also found that E3 given to rats prior to radiation and chemical exposure created a reduction in the development of mammary cancers. Since then, research has shown that estriol blocks estrogen coupling receptor, GPR30, even in estrogen receptor negative breast cancer cells, decreasing the proliferative actions of estradiol. So E3 is very protective against cancer. So this estrogen quotient is a math equation where E3, the level of E3 is divided by the levels of estrone plus estradiol. The lower the estrogen quotient, the higher the risk of breast cancer. So whenever we see an estrogen quotient under 1, we're thinking about this woman having a higher risk for breast cancer or estrogen-dependent cancers, and we really want to see the EQ at 1.5 or above to put a woman in the more protective range. So this is what you will see in your test results. This is what the estrogen quotient will look like. And in this particular case, I just want you to note that estrone, again, the estrogen that has the most potential for harm, is not elevated. It is within the range because we want to see it under 45. It is under 45. But the reason that this woman's estrogen quotient is so low is because the estriol is so low. Estradiol, again, isn't exceptionally high. It's quite low itself at 0.78, but it's that very, very low estriol which is driving that quotient down. So ways in which to use the estrogen quotient. It's a great screening tool for women who are at higher risk of breast cancer, or for women who are already taking Premarin or any form of HRT or even bioidentical hormone replacement therapy. It's a great part of an initial comprehensive evaluation to help you as the provider determine whether or not you're going to be starting any kind of estrogen supplementation with your patients. It's also a great way to monitor estrogen metabolism in patients who are using Premarin, HRT, and bioidentical estradiol. We suggest monitoring the EQ every 3 months to ensure that estrone and estradiol are not elevated. It also gives you an indication if you are supplementing with estradiol, if it's converting into estrone or into estriol. So the EQ just provides a nice broad brush stroke, if you will, for quickly assessing good versus bad estrogen. Is the EQ better than the PGE2 ratio for monitoring estrogen? No, it's definitely not better. It's just another wonderful tool that you have to use. Both of these ratios are highly useful and effective in helping to define treatment. The EQ is a measurement of all three estrogens in relationship to each other, and it helps to determine the risk status for each of your patients. It's specific only to estrogens, whereas the PGE2 ratio is another parameter which will help you to assess your patient's estrogen dominance. So just a little clinical pearl, keep in mind, the PGE2 ratio is used not only to address risk, but also helpful in addressing symptoms. And the EQ is really more about risk assessment and estrogen metabolism. So how do you increase the estrogen quotient to support estrogen excretion? There's a couple different ways to do that. The first would be to decrease the dosage of estradiol that the woman is receiving, whether it's HRT, Premarin, or even bioidentical estradiol, avoiding xenoestrogens, limiting alcohol, supplementing with E3, and fiber. We're going to talk about all those a little bit more at length here. So this is a list of synthetic and naturally occurring compounds in the environment that mimic estrogen in the body and can serve as competitive inhibitors for endogenous hormones. They drive estrogenic reactions just the way that endogenous estrogen does, and as a result can contribute to estrogen dominance. It can also contribute to precocious puberty in girls and even hypogonadism in males and animals. So some of the things that you're need to think about in terms of xenoestrogens, and you want to limit the exposure for your patients, plastics. So the chemical BPA in plastics is very similar to human estradiol and can bind to receptors as well. Pesticides, of course, synthetic hormones, which can sometimes be in the water supply, birth control pills, meats that contain hormones, cosmetics that can contain parabens, even caffeine has some weak estrogenic effects. Food additives, bromide, fluoride, chloride, and in particular, be aware of dairy products. As well, alcohol can increase estrogen levels because it promotes the expression of a cancer-causing gene called BRAF, which has estrogen mimicking and enhancing effects. Alcohol has been found to promote the sustained expression of this gene, even in the absence of estradiol supplementation. So that means that alcohol alone can mimic estrogen in the body and contribute to breast cancer risk. Researchers have also found that the combination of estradiol and alcohol creates an even higher expression of BRAF, suggesting that estradiol supplementation and alcohol consumption may increase the risk factor of breast cancer. This is an article that was written by the founders of Labrix, Drs. Mead and Lohman, that outlines the beneficial effects of estriol. And here's just a quick summary statement going over some of the beneficial effects of estriol E3. A review of 150 articles showed that estriol has, that oral and vaginal estriol supplementation is not associated with an increased risk of breast cancer. It's safe for use in postmenopausal women who were previously treated for breast cancer. It prevents bone loss and increases bone mineral density, even in postmenopausal women. It does not cause endometrial changes in postmenopausal women, even when taken orally. Estriol is effective in the treatment of atrophic vaginitis, especially when used topically. It's safe and effective for the treatment of climacteric symptoms in postmenopausal women. So by climacteric, we're thinking hot flashes and night sweats. And vaginal application of E3 is systemically absorbed. One can use it also transdermally on thin skin tissues. So this is our recommendation for using transdermal estriol, again, either vaginally or transdermally, 1 milligram every day for 14 days or until symptoms improve, and thereafter every other day or 3 days a week for maintenance. A healthy gut is so important for estrogen metabolism. Poor GI health can inhibit the excretion of unwanted estrogen metabolites from the body and promote their reabsorption. So if you remember the metabolite picture going way back, wanting to avoid the 16-OH and 4-OH pathways, having good GI function is going to help to promote that positive pathway. A healthy gut rich with dietary fiber in the form of lignans can actually bind to estrogen and help to facilitate the excretion. So if you think of those lignans as a little transport tool that's going to help to move those estrogen metabolites out of the body. Flax in particular has been shown to increase that favorable 2-OH metabolite pathway, as opposed to soy, which did not have as favorable an effect. So let's talk about some non-hormonal support for estrogen metabolism and excretion. Exercise, diet, nutrition, and specific nutrients that are going to support healthy estrogen metabolism. You'll note the effects of, you'll just keep in mind that exercise has a really powerful effect on estrogen metabolism. 150 minutes of vigorous exercise per week for 16 weeks showed a significant change in estrogen metabolism in a direction consistent with helping to reduce breast cancer. Specifically, an increase in the 2-OH metabolic pathway and a little bit of a non-significant, and as well a decrease in 16-OH levels. So when we're thinking about what are our goals, what are our dietary goals for being able to counterbalance estrogen dominance and thinking about promoting those positive pathways, managing blood sugar to avoid elevated insulin is very important because elevated insulin is going to contribute to higher estrogen levels and it's going to increase to higher fat supply in the body, which is going to decrease sex hormone binding globulin. So the way to do this, to manage blood sugar, one of the most important ways to do this is to avoid simple carbohydrates and sugars. Carbohydrates should come from foods that will provide the lignans and the fiber needed for gut health. This will increase antioxidant levels, which will counterbalance the free radicals produced when the OH16 pathway is stimulated. Omega-3 fats promote the OH2 pathway, which is great, which is, again, the positive pathway. Diets low in omega-3s are going to push the 16-OH pathway. So again, just talking a little bit more about the importance of the diet rich in lignans. It's going to help to stimulate a sex hormone binding globulin, which is going to keep hormone levels in check. And it's also going to inhibit aromatase activity, which is going to decrease the conversion of testosterone and androstenedione into estrone in fat and breast cells. Women who consumed 10 grams of flaxseed per day experienced longer menstrual cycle length, increased progesterone to estrogen ratios, so a positive PGE2 ratio, and fewer anovulatory cycles when they were on the flaxseed. So some foods that are high in lignans, we've been talking about flax, obviously sesame seeds as well, curly kale and broccoli, apricots, cabbage, Brussels sprouts, strawberries, tofu, and dark rye bread. Keep in mind that anytime a woman is on hormone replacement therapy, again, the synthetic forms of hormone, there is going to be a reduction in their nutrient status in their body, whether that's oral birth control pills or HRT. And the nutrients that are going to be depleted are B6, magnesium, CoQ10, and folic acid. And as a result of the B6 magnesium depletion, HRT is often associated with depression and low mood in women. So let's talk about some ways to balance the PGE2 ratio, progesterone, nutrients, and herbal support. So this is what we recommend as a starting dose for progesterone to counterbalance the effects of estrogen. We're thinking about 20 to 60 milligrams per day. We recommend twice-a-day dosing for women who are experiencing those peri and menopausally related vasomotor symptoms. So we start with weight. For women who weigh less than 150 pounds, we usually recommend starting them at 20 to 30 milligrams topical progesterone. And for women who weigh over 150 pounds, we recommend starting at 40 to 60 milligrams topically. And again, keep in mind that progesterone is much better absorbed topically than it is orally, again, because it's bypassing the first pass liver effect. So some non-hormonal supplements that support the favorable PGE2 ratio and address estrogen dominant symptoms. There's quite a lot that I'm going to be rattling off for you, so just hang in there with me while I do this. A couple of them I'm going to be pointing out, giving you a little bit more detail. But magnesium can help to reduce water retention, pain, cravings, and anxiety associated with PMS. Vitamin C can decrease the free radicals that are associated with HRT use. Vitamin E improves corpus luteum blood flow and increases serum progesterone. L-arginine also improves that corpus luteum blood flow and increases serum progesterone. B6 will help to reduce estrogen and increase progesterone and will improve PMS symptoms overall. I'm going to talk a little bit more in detail about indole-3 carbinol and DIM. These two compounds have both shown a benefit in promoting the healthy metabolism of estrogen. And there's evidence that DIM may be a little bit more stable and have fewer byproducts and side effects. Keep in mind that the I3C is produced when cruciferous vegetables are chopped or chewed. When it combines with stomach acid, it breaks down into DIM. So it's just a little bit further along the conversion pathway, DIM is. I3C, as we mentioned, comes from cruciferous vegetables, and it promotes the 2-OH breakdown pathway of estrogen. And DIM specifically can block estrogen receptors and inhibit the growth of estrogen-responsive breast cancer. And it's been shown to inhibit the growth of both estrogen-dependent and estrogen-independent cancer cells by approximately 60%. So a really powerful tool for these women who do not have a favorable estrogen quotient. Some more supplements that are going to support a favorable PGE2 ratio. Tribulus terrestris is going to promote ovulation. As well, Vitex, which is also known as chaste tree berry, is really wonderful for helping with estrogen dominant symptoms. Research has shown that it's helpful with breast tenderness, irritability, depression, and headache. Resveratrol, everybody's favorite, is found in the skin of red grapes as well as peanuts and berries, and it has it's the reason that wine is considered a potent antioxidant. It's because of the resveratrol that's found in the grape skins. It's been shown in vitro to inhibit breast cancer cell growth. It has estrogenic and anti-estrogenic activity as it binds to the receptor sites and helps to serve, again, as a competitive inhibitor. It also has very well-known anti-cancer and cardioprotective properties. Calcium glucarate is the calcium salt of D-glucaric acid. It's produced naturally in small amounts by mammals and humans. It's found in many fruits and vegetables, with the highest concentrations in oranges, apples, grapefruit, and cruciferous vegetables. It inhibits beta-glucuronidase, which is an enzyme that's produced in gut microflora. An elevated level of beta-glucuronidase activity is associated with an increased risk for hormone-dependent cancers, breast, prostate, and colon. Oral calcium D-glucarate has been shown to regulate estrogen metabolism, inhibit carcinogenesis, and promote cellular differentiation. So really another wonderful tool to help with the PGE2 ratio as well as estrogen quotient. Again, there's those omega-3 fatty acids. Again, they've been shown to push that the 2-OH pathway and decrease the 16-OH pathway. And here are some other supplements that are going to be supporting the PGE2 ratio. We're going to talk about vitamin D, curcumin, and melatonin in a little bit more detail. And right now we're going to talk a little bit more about the natural aromatase inhibitors. So those natural aromatase inhibitors are chrysin, a bioflavonoid, zinc, and saw palmetto. Be careful with saw palmetto is that there is some new evidence that's suggesting it may not be safe for women who may become pregnant. So in your premenopausal women, probably best to stay away from saw palmetto if there's any chance they may become pregnant. How does vitamin D prevent breast cancer? It binds to a specific nuclear transcription factor known as vitamin D receptor, VDR. And this modulates the transcription of more than 50 genes that promote differentiation and apoptosis to help prevent proliferation. So vitamin D can be a very powerful tool in cancer prevention. Keep in mind that vitamin D insufficiency is an epidemic. A recent survey found that 90% of the population with pigmented skin and 75% of the white population have insufficient levels of vitamin D. 85,000 cases of breast cancer could be prevented in North America alone with sufficient supplementation of vitamin D. A study out of San Diego on breast and colon cancer found that dosages of 3,500 IUs per day would reduce breast cancer by 50%. Curcumin is a naturally occurring compound found in the spice turmeric, and it's a member of the ginger family. A combination of curcumin and the isoflavone genistein from soy has been shown to have synergy in reducing xenoestrogen-induced growth of breast cancer cells. So breast cancer cells that are being induced by those artificial estrogens in the environment. Curcumin has also been shown to increase hepatic levels of the very potent antioxidant called glutathione, and it induces phase 2 detoxification of quinones. Melatonin, the hormone that's released in the middle of the night, is manufactured only at night to regulate the sleep cycles. Scientists have speculated that the lack of melatonin, due largely to our sleep-deprived culture, puts women at higher risk of breast cancer because there's an inverse relationship between melatonin levels and breast cancer. So across the board, in women with breast cancer, they are found to have lower melatonin levels. As well, melatonin can actually modulate estrogen-dependent pathways and reduce free radical formation, thus preventing mutation and cellular toxicity. So it's a very potent antioxidant. So when and what to test? Initially, we recommend the comprehensive hormone panel, which will include the 3 estrogens, as well as progesterone, testosterone, DHEA, and the 4 cortisols before initiating hormone therapy. We recommend every 3 months to look at the EQ, the 3 estrogens, to help monitor the effects of Premarin or HRT, and the PGE2 ratio if symptoms are being reported, and DHEA and testosterone if somebody is supplementing or if levels are elevated initially. Keep in mind that if somebody is on DHEA, it's really important to be testing on a regular basis to monitor whether the DHEA is converting into testosterone or estradiol. Once balance is achieved, one can reduce testing to annually. And of course, one can repeat testing sooner as symptoms, with the onset of new symptoms. Cortisol levels take a little bit longer to change. We usually recommend going 6 to 12 months before retesting cortisol levels. This is a lovely picture that a dear friend of mine took of the 3 sisters with beautiful wildflowers in the foreground. So I just want to say thank you so much for attending the webinar today, and